Welcome to The Patient Physician, a space for doctors to explore their physical, mental, and financial wellness. Your peers and industry leaders will destigmatize institutional perceptions while redefining success, money, and personal care. Get ready to pull back the curtain, because here, you are both patient and physician.
And welcome to The Patient Physician. My name is Paul Smith, and I'm joined today by my co-host, Chris Fulbright.
Good morning, Paul. How are you, buddy?
I'm good. You know, medicine is always changing in the way that it is delivered, and today's guest is no exception in how he's helping drive that. Today, we're joined by Joe White, the founder and CEO of SendIt Healthcare, which can also be found at senditgigs.com. Joe is a Las Vegas native, began his career sweeping floors at a local HCA healthcare hospital before advancing into the C-suite. After earning his MHA from the University of Minnesota, Joe returned to HCA, where he spent nearly 10 years in senior executive roles and graduated from HCA's prestigious executive development program. Following his time at HCA, Joe joined the corporate management group focused on staffing hospital-based providers. These combined experiences, both as hospital executive and a physician staffing leader, gave him the firsthand insight into challenges facing the locums industry. This unique perspective led Joe to launch SendIt, a solution designed to connect healthcare systems with high-quality, affordable providers. Welcome to the show, Joe. Glad to have you.
Thank you. Thank you guys both so much for having me on. It's great to meet you.
So I'm going to tell you right off the bat, I love the beginning of your story that you started by sweeping floors. And not only does it speak to the ability still in today's world to move up and through an organization, it actually allows you another perspective to see all the parts of an organization. And I'm just wondering, as an entry point, do you think that is why you ended up where you are now? And would you have even been here if you had started right out in the executive role?
Oh, no, not at all. For sure. I think that I look back on that experience very fondly. I was studying medicine and I always wanted to help people, and that's just where I wanted to be. And me and my cousins, we're all going through the pre-med program, but my mind was much more like process-oriented operations as well as like financial. And I really loved those classes. And so then a hospital CEO came and spoke at my school, and I was like, whoa, I never even thought about like the business side of healthcare. You know, it was always just the medicine side. And so I said, I'll do anything. I'll sweep your floors. I just want to learn about how hospitals operate. And so that kind of just started my entry path in there. I started working in the ER as a tech and doing EKGs and seeing how process flow. And, you know, 80% of your hospital volumes coming through the ER. And what does that look like? And surges and census. But then they started to figure out that I was really good at PowerPoint and Excel. And so when they figured that out, I started doing all their little projects on the side. And so half the time I'm down there sweeping the floors. The other half the time I'm doing an Excel spreadsheet on, hey, what new project do we need to do and how much capital is going to be required here and there. And so that kind of started my process that way. And then eventually I was pretty much the CEO's assistant. And so I was outside of his office just taking notes and seeing all the people he was interacting with, and then decided to go and say, all right, this is my path. And that's how I got there.
Cleaning up the healthcare system, one broom sweep at a time.
Love it. Well, you can tell I've been in healthcare for a while because of my bald head, right?
It's already wearing on you, huh?
Yeah, exactly. So people can tell that I started from the bottom because I lost my hair so early.
On the way up, it was the climb. It was the climb up.
Exactly.
Yeah.
A friend of mine always said it's not going bald, it's just that it's falling backwards. So
yeah.
I don't know if that's true for everybody. Well, tell us a little bit more about yourself and your path to where you're at now.
Yeah, so born and raised in Vegas, just kind of like you said. And then I went through the HCA Executive Development Program. And then I was COO of a hospital in Southern California and then one out in Nashville. And when I was there, we kind of dealt with COVID and we had these surges and spikes and needs, and we needed more nurses and more doctors, and things were kind of going up and down. And I started interacting a little bit with Locum Tenens, which was a very interesting term to me. I mean, we'd used them occasionally, but these temporary doctors. But in the same vein, it existed in the nursing space where we were paying all this agency overhead fee just to get a provider, whether that be a nurse or an APP or a physician, to the bedside. And it was costing so much money that we were just like, how do we control these expenses, but also take care of the patients? And so I eventually switched over to the physician staffing space. It was a private equity-backed physician staffing company. And that's where I experienced it even more, right? I remember paying thousands of dollars of bonuses to get a doctor to pick up shifts. I remember sending flowers to a doctor's wife because he had to work on their anniversary because I just didn't have a deep enough bench. And when I needed a doctor, I had to go to these agencies and they were so expensive. And so I was like, why has nobody created a marketplace where I can just connect directly with the doctor? And there's not all this agency overhead. All the doctor cares about is the hospital, and all the hospital cares about is the doctor. So kind of like a dating platform where I just kind of start connecting the two and keep my overhead as low as possible. It's better for both the doctor and for the healthcare organization. So when I didn't see that solution, I decided to launch SendIt. And that's really how I got the name. My brother-in-law's like, so what are you going to do? I'm like, I think I'm going to launch this business. Like, it's got to work. It makes sense, right? And he's like, send it, go for it. And so we just called it SendIt Healthcare.
That's a great story. So it was through having both of those sides of the experience of that coin, if you will, to be able to come up with that idea, that compression to create the insight on how to do it. Was there an exact moment that you realized, because you're pretty vocal about, how you saw firsthand how broken the physician staffing can be. And so I don't know if there was an exact moment or if there's an epiphany or day that you realized you had the knowledge and there was a way to start rebuilding this.
I think it was like more watching the macro dynamics of what's changing for physician employment in the space, right? So I was on the private equity side, obviously, and we would purchase groups and we'd get contracts and we would try and win these contracts. And we see in like the past 5 years, a rapid expansion into doctors being employed versus having ownership. And I married into a physician family. So my father-in-law's an oral surgeon. My brother-in-laws are oral surgeons, right? My father-in-law owned his practice. And then now my brother-in-laws, they did own their practice and they sold it to a DSO. And so I kind of witnessed firsthand, like what happens when those dynamics change, right? What happens when you go from an owner to a renter? And so I kind of felt like Locum Tenens has not been a massive industry. In the past, it actually has a very kind of negative connotation. It used to be like the doctors who couldn't get along with anybody, right, that didn't want to be in a group and just would travel and were just trying to get the most amount of money and they weren't always the greatest. And now we see that's actually changing significantly. Like a lot of doctors are burnt out or they want to work on their terms and they don't want to work for this individual or this corporation or whatever it might be. So they're like, how do I operate as an independent contractor? So I think it was just more like the macroeconomics where I just kept seeing this and experiencing it firsthand, where I was like, wow, like we are really struggling recruiting providers and physicians and APPs and all of them. And a lot of it is because there is this change in how the new generation wants to work and how they expect their life to be. They care a lot more about balance. They care a lot more about predictability than they do about all these other factors.
So what do you see as the top structural issues that lead? You talked about burnout, which is not a new subject on our show, but
it's a theme almost, right?
Really,
I mean, we're seeing it. We're seeing it from all age groups. We're seeing it as people are young. They're coming out of training. They're already feeling burnt out. Then they're hitting that first season of their career, and they're like, "Is this what I spent 15 years trying to get to?" Right? And then you have older physicians that are like, now that I'm on the treadmill, how do I get off of it? I mean, this burnout thing that you're describing, Joe, is prevalent, and it's kind of flowed through, Paul. Didn't mean to interrupt you, Paul, but that's
no. That's
right.
That's
I was
exactly
thinking the exact same thing that Joe said. Yeah,
it's prevalent all the way throughout. But are there the top structural issues that you can identify that lead to that, to coverage gaps, or even the rising costs that you mentioned earlier?
Yeah, I think it's the perfect storm of so many things. I think it's the changing and generations and how they operate. I think it's the burnout. It's the demand that's out there for physicians right now is extremely high. And so you see doctors are picking up more and more shifts. And there were times where I would, offer a bonus for a doctor to pick up a shift. And they're like, you can't pay me enough. I'm just so tired. Like money's not even a factor anymore. I'm just burnt out. And that's where I was always like obsessed with this. How do I deepen my bench with physicians that are wanting to pick up shifts and, start to expand outward, right? You might have a rural hospital that only has 4 or 5 doctors who pick up coverage, and then one goes out, and then 3 of them are left picking up the ER 24/7, and they're starting to get burned out as a result because we don't have the mechanisms to have a much more fluid physician workforce. I think that causes a lot of the burnout. I do think that, student loans is just killer for doctors right now. It's crazy how expensive it is and how much they come out with debt.
Mm-hmm.
And to your point, they train for 15 years and then it's like, okay, now what do? I have to do this for the next 15 years, and it gets very tedious and very difficult. And, they want to be able to be stretched and try new things, but they also sometimes can feel stuck because they've got this debt. They put so much time and effort into training that they're like, I have to maximize the value that I am. Right. So I think there's a lot of dynamics that are kind of pushing it that way.
Mm-hmm. So you're talking about really what seems like a physician shortage, that the people you're talking to and offering all whatever kinds of money that you can offer them, and they're still saying no because they're overworked. I highly doubt there's an underworked group of physicians out there that are saying, hey, so can you talk to that? Is there, I don't know that there's a single solution. Obviously, if there's a physician shortage, how do we get around these problems of staffing?
Mm-hmm. Yeah, that's a great question. What I find interesting about job boards or different things like that, like SendIt, we're not a job board because I feel like a job board doesn't actually solve the physician shortage at all, right? You're just moving one doctor to another location, but then that just opens up things, right? So a job board is not going to solve the problem. I do think that there are many doctors out there that have some capacity that would be willing to provide more support if they had a mechanism to do so easily, right? So there might be a doctor who lives in Nashville who will pick up 2 or 3 shifts a month in Cookeville. And that's kind of what we do. It's like 2 or 3 hours away, but it's not easy for them to do so. There's credentialing, there's scheduling, there's all these different things that we make very difficult for a doctor to be more fluid to pick up shifts. And so that was kind of like my strategy when I started dealing with the physician shortage, is I'm like, okay, we don't have density here in this location, but is there a city, a couple hours away that might have a few doctors that are willing to pick up 3 or 4 shifts? Instead of me flying somebody in from New York or from California, can I find somewhere else where doctors are coming out, maybe at a residency, and are like, hey, I've got my full-time W-2 job where I have to work 120 hours a month. However, I would pick up 2 or 3 shifts at the right rate at a facility where I feel comfortable if it were given to me. And so that's where I feel like SendIt is a little bit different, in the sense that we're trying to help address the shortage by seeing if there's anybody who has capacity out there to pick up more additional shifts, right? Anybody who might be retired, who's an anesthesiologist that was like, hey, I left, I sold my practice, right? Sold my practice and it was great, but I want to keep my licensure up. I want to work 4 or 5 shifts a month, but I want to work on my terms. I don't want to work however you tell me to work. Mm-hmm. I will upload my availability and I'll send it out to 10 hospitals and they can all pick and choose when they want to use me. I think that allows a hospital to then address some of their challenges when it comes to that physician shortage.
You mentioned something about the credentialing and the process and that's difficult, even just to get it to where the physician can come in and work. Is there something that SendIt's doing on that side to help smooth that transition or that process?
Yeah, there's a lot of things that we're working on that are going to help it even more. But the biggest thing is, whenever a doctor gets credentialed at a location, they ask for the 90% of the same documents at every location you go to, right? Licensure, mm-hmm. DEA, ACLS, all of those things. So we have what we call a credentialing wallet, which is where doctors can keep and store all of their credentialing documents, and they just upload it once. And then every time they go to a new location, it's very easy to send that. And then we do assign them a credentialer who helps support to fill out the packet. I believe, obviously, with AI and other solutions, that's going to be very simple someday, that we're going to be able to have some sort of an agent that can review all of their documents and say, hey, I filled out this packet to the best of my ability. Here's all the answers based off of all the information you have. You just need to sign here, initial here, good to go, right? So I see a future where credentialing becomes much more seamless. We also see that doctors, like with EHRs right now, like most doctors know how to use the big 3 EHRs, right? So that's not as much of a barrier anymore when you go into a hospital of like, oh, I need orientation. Orientation mm-hmm. isn't that hard anymore because you know how to treat a patient in just about any facility, so long as they got the same documentation and EHR that you've used, whether it's in residency or training or medical school. Most people come out and they're pretty synonymous, right?
Paul, we had somebody on that, the physician, he's a pediatric, talked about locums. One of the things he had talked about, Joe, is, he moved state to state. He had the things, and I know that you brought up the compact, the interstate medical licensing compact. Can you talk a little bit about that as mm-hmm. a solution? As you talk about the wallet as a place for efficiency of holding mm-hmm. credentialing, can you talk more about the compact as well?
Yeah, for sure. when you're going to do travel work as a physician, you want to maximize your value. And what is the value that a traveling physician can provide, right? I would say in IMLC, what we see on our platform is the typical doctor makes 20 to 25% more if they have an IMLC, right? And this is a very new thing that's kind of becoming very prevalent amongst doctors, is if they have an IMLC, they can work in 40 states and get that licensure within 7 days usually. And it costs about $700 for a doctor. And it's kind of been an accelerator for travel work. So having an IMLC and maintaining 2 or 3 DEAs that you can switch from state to state, depending on where you're working, allows a doctor to pick up more shifts and to maximize their availability, right? Because there might be a shortage in Mississippi, but there's density in Texas. So how do we then get those doctors that are in Texas over to Mississippi? Well, the ones that have an IMLC are going to be the ones that are picked up first by that hospital that needs those doctors, right? So it's all about maximizing your value. There's also your availability, right? Your years of experience. That's what drove me crazy when I worked with Locum Tenens agency. Like, the cost and quality, there was no correlation between the cost and quality of the doctor, right? I worked with this agency that was trying to get me at the highest price point and the doctor at the lowest price point. And I'd have a really good doctor over here who could be making half as much as the other doctor who's really low quality, because there was just no quality or data endpoints that I could kind of use to make a decision, right? So luckily on our platform, we just charge 9% on top of the doctor. If a doctor's like, look, I got 10 years experience, I have no medical malpractice, I have an IMLC, I charge $400 an hour for my services. You want to take the one that's $300 an hour? That's fine. That's what you're going to get. You get what you pay for. But I never experienced that when I was dealing with the locums. I never got what I paid for, right? I just got a massive bill that I was like, this makes no sense.
Well, it sounds like you've built SendIt around a lot more transparency and even physician choice. So tell us a little bit more about what that looks like in practice, even for the hospitals or institutions that are hiring these people, because it sounds like there's some benefit to them now too.
Yeah, I mean, I think obviously I built this with any marketplace should benefit both parties, right? It's difficult because you have two customers, but the transparency is really what helps. And so we certainly do that. Like when a doctor creates a profile, it takes like 4 to 5 minutes, and they set their own rates. So we don't tell the doctor what rate to set. Now, we do have a calculator out there that shows them what the market rates are based off of their specialty.
Some guidance or something.
Right. Yeah. So location, here's some guidance, and here's what we see. But you can set your own rate. Whether a hospital takes that or not is not on me, right? The market determines what the actual worth of that physician is, right? They're the ones that are buying. The hospitals are the ones that are buying. They're going to make their decision based off of price point and quality and other metrics that are very important, maybe availability, for example. We also do have some rating aspects in there, right? So like physicians can get peer references, kind of like endorsements from LinkedIn, where it's like, hey, I've worked with this doctor. He or she is incredible. They're really high quality. That helps with their rating and review. And that helps a hospital say, okay, maybe I'm willing to pay $10 or $15 more an hour. Because I will tell you, as a hospital executive, I cared a lot about the quality. Like, I'm willing to pay $10 or $15 more an hour if a doctor is going to go out into the lobby and see a patient, so that they don't leave the hospital what we call AMA, right? If they leave AMA from a hospital perspective, that's revenue that we lose because that patient wasn't seen. If you've got a doctor who's very efficient, who's like very forward, who's like, hey, I'm going to go out there, I'm going to make sure that I see all these patients, they're going to enjoy it, they're going to have a good experience, I'm going to get your HCAP scores are going to be up. That gets more reimbursement for me. I get better Google ratings, all of those things. Like, I would tell my team, like, take the one who's $20 more an hour every single time. Because where I think doctors are starting to learn more, but don't fully realize, is that they are revenue generators. Like, they are what brings the patients into the hospital. And that's where we make our money as a hospital, right? And so I think doctors need to be more comfortable understanding that they add value to the hospital by allowing them to generate more revenue, right? If I have another anesthesiologist, I can do more surgeries, right? I bill and collect for those surgeries. That's great. If I have a cardiologist, I can do more cardiac procedures, right? All of those things help me generate more revenue. And so the doctors need to feel that ownership and that, like, hey, I understand my worth and my value. And that's why we focus on transparency.
Yeah, I mean, that makes sense. The patients can come to the hospital, but if they can't be seen, then you can't generate revenue. And it still is a business at the base. Obviously, we want to take care of patients, but it's still, it is still a business of medicine, really. I wanted to say, you said that you noticed the challenges for doctors who wanted to, I'm doing air quotes here, try to buy for jobs. What did you mean by that?
Yeah, I just think that you have this massive gap between I'm employed here, things are changing, right? Maybe my group was just purchased. Maybe the contract changed. Maybe the hospital is bringing the services in-house. Like there's lots of dynamics, and the physicians are kind of many a time stuck in that scenario, right? They don't necessarily know what's going to happen. They don't know what the future is, or maybe they're changing even their compensation model, right? And they're changing how many APPs they need to oversee, a lot of different things. And so they want to try a different space, but they don't. The only options out there are locum tenens agencies. And there's a massive gap between those two, because you go to a locum tenens agency, they're going to charge 40% on top of you. They're also going to have this massive buyout. And many times doctors don't know that there's this buyout fee. If the hospital wants to recruit them, then they have to pay the agency $20,000. And I can guarantee you, having sat in that seat, that comes out of the doctor's sign-on bonus, right? That $20,000 doesn't come out of nowhere. It's like, well, we're going to have to pay $20,000 to recruit this doctor. And
do they know that?
Offer that. No, the physicians don't know, right? Like this whole space is a black box, right? Like the more we keep it a black box and the less we talk about it, the better it is for the large locums agencies, right? And so I'm kind of like the anti-agency. I don't know, that might end up getting me killed, right? But like the more
I hope not.
Yeah. but the more I like interact in this space, like the more I'm just totally disenfranchised with it. It's just like, it doesn't do right by the hospitals and it doesn't do right by the physicians, right? So we want to be that try before you buy solution. Like on a dating app, you don't pay the dating app when you find your spouse, right? Like that's stupid, right? You're already paying the dating app to help you date. And so why, when you join SendIt, would I charge a buyout if you find your long-term fit? Like that doesn't make any sense, because you might be there for 2 or 3 years. And I will say the divorce rates between a hospital and a doctor are much higher. That doctor will be back on my platform in 2 to 3 years, right? And so it's like, it's not a terrible thing. I mean, it's got to be the worst thing for a dating app when somebody gets married, because it's like, gosh dang it, we just lost a revenue.
They lose a client. That's right.
Yeah.
Right. They lose a client. But for me,
maybe,
like,
maybe they lose a client. Maybe not. Yeah.
Maybe.
It'd be a little awkward if you had decided to get married and then you're like, I don't know that I want to pay that price though.
Yeah, exactly.
Right.
I'm going to keep shopping.
Coming out of the ring. Yeah. That
coming out of my
buyout. Your ring got smaller. Yeah.
Yeah. Well, I think it's funny that you bring that up, because I'm sure you guys talk about it a lot with your physicians and stuff, but like the corporatization of medicine. I feel like physicians are becoming more attuned to the hold up. Like, of course they always have their oath that they're going to keep, and that they're like, do no harm, and they're focused on the patient, but they're starting to ask a lot more questions about like, but how much money do you make off of me? And why this model versus that model? And how does that change these dynamics in that relationship? I think that physicians are care a lot more about that than I've ever seen, right? They care about the balance, but they also care about understanding the economics behind healthcare. And that is empowering them to make more decisions. And so it's kind of funny you bring that up, because I just feel like, like many a times doctors are wondering like, okay, what is out there and what is the market saying? And the market's not super transparent right now when it comes to rate, when it comes to quality metrics, and when it comes to balance. It's very hard for them coming out of residency or being in a job for a long time to figure out like, what is real? Is the grass greener on the other side, or is it not greener on the other side?
Mm-hmm. So it seems like you're kind of talking about them having just more control over when and where, how they work. And so to that, what can you describe what true autonomy, if in this perfect world, what does that look like in today's healthcare environment?
Yeah, for now, operating within today's healthcare environment, I would say after the physician creates their profile, they are sent connection requests for hospitals where they're a match, right? So they get sent the request, they see the electronic health record, the location. So it's kind of like a matching criteria. They're anonymous to start until there is a match on the platform. And once that match happens, you see all the details about the hospital. They don't see any of your details until you say accept, right? And so those biggest things that need to be determined up front are, are you working in the specialty I need as a hospital, right? Do you have the board certification and the licensure I need? So we get all those details from the doctor up front. We kind of have some API integrations that help out with that help with the match. And then the doctor reviews what the hospital says. And then we put the two of them together. And then that kind of starts the conversation process. Like, okay, hey, here's a doctor licensed in Texas, willing to work 4 or 5 shifts a month, and has all the criteria you need to be able to work there. And then the hospital then reviews that physician's resume and then decides whether they want to move forward or not. And then we start the credentialing. So I would say in a perfect world, a doctor has 4 or 5 different hospitals that they are connected with on our platform that are all looking at the doctor's availability. Because once they have that connection, the doctor then uploads 4 or 5 shifts that they're willing to work per month on our platform. It's kind of like Calendly. You just add your availability and then it shares it out to the 4 or 5 hospitals. And then whoever picks it up first gets it, right? So that's kind of what that relationship looks like. And that obviously comes from my experience of like, hey, like I know that a doctor's a revenue generator. If I can get that doctor on a Friday, then I'm going to do my best to get that doctor on a Friday because that means I can bring in a surgeon to do more operations on a Friday. So Friday might not be ideal for me, but it's still better than nothing, right? Because now I can generate more revenue. So it allows the hospital to kind of like look at the doctor's availability and determine, okay, hey, how can I fit this doctor into my schedule, into my hospital? Because I know that I'll be able to expand my service line as I do so.
So is that something that they're doing regularly, or is this by shift? I mean, how are they filling this in?
Yeah, regularly. And some of our doctors get booked out for a whole year, which is incredible, right? So some doctors upload their availability and just they put all their vacation days in there and they're like, hey, I'm working travel full time, and the hospital really enjoys working with them, and they'll book them out like 14 or 15 shifts a month, right? Because the doctor can put the max number of shifts in there. And then some doctors are just updating it. Usually most locations write their schedules 60 to 90 days in advance. So we just asked our doctors to like, hey, once you have your home location, once you have that schedule, upload some availability for your locations to be able to match with. And then once you match, that's where the relationship kind of continues long term, right? This is not meant to be kind of like I'm going to pick up 1 or 2 shifts with this hospital, then I'm done, because that's too much of a headache for both parties to go through that entire process to pick up 1 or 2 shifts. This is meant to be like again, I'm deepening my bench with a doctor who has some availability and is willing to share that availability with me. It's on me to figure out whether I'm going to use that availability or not. It's on me to say, all right, I'm going to move my schedule around to try and get this doctor in here because they're high quality. They're going to help me grow my service line. That's where it really works.
The listeners of this are busy physicians, right? They're walking hallways, they're doing notes, they're in between jobs. Of course, we're going to put a link to your website in here, but the technology on your website, right? You're like, sign up for this. It's a couple minutes. And then we've seen it. Can you paint a picture for somebody to kind of entice them to go to the website where you have on here the technology that makes it easier, the pending, what are they seeing, the transparency of their hours? Just paint that for them to get them to go to your website to test it. Because what I found is just like anything else. If Paul says, I'm a financial advisor, right? And someone says, oh, I dealt with a financial advisor 8 years ago, whether that relationship was good or bad, it becomes a label. They put it on the shelf. They never go back and test. And so if someone says, oh, I've done Locum Tenens. Oh, I know what that's all about. Oh, great technology, right? And you use the illustration between an Uber and a taxi or Airbnb versus something else, right? The leverage of technology. Can you paint that picture for somebody to entice them to go and see how smooth of a transition you've made this for these physicians?
Yeah, and I hope we keep making it even smoother. But your analogy, that's perfect. Is that many times people ask, well, what's the difference between you and a locums agency? And I say, well, what's the difference between a taxi and an Uber? Both get you from point A to point B, but you'll use an Uber every time over using a taxi, right? Because it's just the ease of it and how they communicate. So very much similar to what you might see on signing up to ride an Uber, right? You do have to put some social proof in there. You have to put in there a couple of references when you sign up. You have to put in your NPI number. And then we pull some data out there that exists in terms of what's your specialty and what's your state licenses. And you kind of confirm those things on our platform. And then you say, yep, I'm good to go. Go ahead and list me on the marketplace. And then when we have a match, the doctor gets a text message right away. And it has a link to the match and it has all the details. So that's a big thing for us. Is what I saw in this space is like, so many times it was this black box of the doctor didn't know how much they were going to make or where the location was, right? There's these headhunters and these recruiters, and you guys probably hear it. The doctors are getting called like 5 or 6 times a day and a bunch of text messages. And it's just like, look, that's not how we operate. You click that link, you see every detail that we know about it, where the location is, how much they're willing to pay. Now, the doctor sets their rate, but if the hospital's wanting to pay, let's call it 10 or $15 cheaper, it'll cross out that rate and say, hey, they're only willing to pay this much. Are you still interested? A lot of our doctors wanted that because they didn't want to miss out on an opportunity that might be really great in a city that they want to work or an opportunity that they really want. So having your listed price on the marketplace is nothing more than giving some data and benchmarks for the hospitals to see like, oh, the average emergency medicine physician is listing their rate here. And what actually works pretty well for us is that they then come onto our platform and they see that the rates that our providers or that our physicians are charging are actually very reasonable, right? And so it's usually the agency that is the problem because their overhead is so high, and that's what gives the negative connotation too with locum tenens. Is having been a hospital executive, I'm like, oh, I never want a locum tenens in here, right? And I was really not thinking about the doctor. I was thinking about the cost of a locum tenens. It's just so much more expensive, right? But a SendIt doc, I hope that someday SendIt is like, oh yeah, no, we can have SendIt docs are perfect to have in here, right? Their rates are reasonable, they're high quality, and if they want to join full time, they can join full time once we have a full time spot for them, or and that's great. But usually doctors do make a lot more money on our platform than they do working for an agency or working directly for the hospital, and that's just the nature of gig work, right? Gig workers always are going to make 20 to 30% more than a full-time person because, they're 1099 and there's no guarantee by either party, right? There's no guarantee. That's kind of the beauty and also the risk that comes with being a locum tenens. And there is a lot of risk that comes with being a locum tenens. I can talk about that too, right? And I'm trying to mitigate that, but until we have that full marketplace density, it's very, very difficult, right? You got to have the jobs to get the doctors and the doctors to get the jobs. And we're still, we're 2 years in and we're kind of working on those two sections, right? So we don't have every specialty. I'll get like a trauma surgeon that signs up in New York and I'm like, I don't know if there's a trauma hospital in New York that needs a trauma surgeon right now, but I'll see what I can do, right? But that's why we are kind of like hyper specialized in emergency medicine, internal medicine, anesthesia, radiology. That's where a lot of our density is right now in hospital-based providers, because that's also where a lot of our jobs are.
You said that the physician rate that they are getting to select, and then your rate is 9% on top of that. But you said that normal locums companies are 40%. So there's obviously a delta there. So who's getting the savings? It sounds like the hospital, based on what you're saying, because they're able to save a little bit more, or are the physicians able to drive up a more reasonable rate? Somebody's saving.
Yeah. I think usually, majority of the time, it's a little bit of both, but it's more in favor of the physician on our side, because the hospitals are used to paying a rate, and I can't determine what the market calls for. Like, this is what the market wants. This is what the market's willing to pay. You can put your rate at $1,000 an hour on our platform. Doesn't mean you'll ever get a connection at that rate, right? And so really the hospitals, they might save a little bit, but I think that they're more focused on the fact that there's no buyout for the physicians, that they could try before they buy and bring the doctor on full time. That's where they really get intrigued. And then the doctors on our platform, they like the transparency, the tech, and then they like making a little bit more money than you do through an agency. And I'm totally for that, right? Like, I think if anybody should take that delta, it should be a little bit more towards the physician than it should be towards the hospital, because they're already getting savings by not having a buyout. They're already getting some savings by the doctors being more local or more regional, right? They save on some of those travel expenses as well. So they've got other mechanisms that are allowing them to save.
Is that 95,000? I think it's a vacancy rate or something you referenced on their website savings.
Yeah.
Is that what you're referring to as the ongoing? Okay. Yeah.
There's so much, having been in that space of how much I would pay in a bonus, how much I would pay to travel, and how much I would pay to get a doctor to buy them out of their contract, that there's a bunch of savings for the hospitals. But for the doctors, certainly I would say why we've been able to grow so much among them is they go and work alongside peers and they talk, and I'm okay with it. Agencies don't want you to talk, but they talk to each other and they're like, hey, I'm a locum tenens, and they're working next to another locum tenens. They're like, how much are you making? And they're like, $200 an hour. And mine are like, I'm making $230 an hour. It's like, well, we're doing the same work. And it's like, yep, but I work through SendIt and you work through an agency. And so I keep more of my pay. I keep more of my take home. And again, my goal is to make sure that we're so efficient that that's always the case, right? Like, when you're booking an Airbnb, you don't go outside of Airbnb. You're okay with the 10% overhead because you have some security, you have a contract, it's going to be clean. There's all these different things. Like, you're not going to go outside of the platform to book that Airbnb, right? The same thing is going to be the case with our physicians, right? Like, we want to keep our overhead so low that it makes sense for the doctor to be on our platform and the hospital to use the platform because there's so much ease of the technology and connecting and sharing my availability and credentialing the doctor that it wouldn't even make sense to try and go outside of the platform to save an extra 9%.
Is there something that, a 40 to a 9% is a dramatic difference, right? You've been in the management world. You mentioned PowerPoints and Excels. So we've all seen the revenue numbers. Is there something you're not able to do through your organization that agencies do? I mean, do agencies, are they helping with travel? Are they helping with medical malpractice? Are they helping with organization? I mean, that 31% delta on a business is enormous, right? So is there something that you're saying, hey, less cost, more technology, but because we're taking such a strange, we don't do X for you, you'll need to coordinate that yourself? Or are you like, no, the times have changed. Technology allows us to do all these things more efficiently. Therefore, we're going to pass that savings along to you.
Yeah, I would say it's more of the latter, but a little bit of a mix. Okay. So we charge 9%. And then with the hospitals that we work with, we determine who will cover the medical malpractice. So if they want us to cover the medical malpractice, we can do that. And then we just charge on top of that. And that goes to the hospital. If the hospital is willing to pay for it themselves, then they get that savings, right? So that's another 4 or 5% that it's like, yeah, we still coordinate your PLI to make sure everything's safe. But at the end of the day, you just want to make sure that you got PLI and tail coverage, and we'll make sure that that's the case. Whether we're negotiating directly with them to get an A+ policy and say they need to be on your medical malpractice, or we're providing it for the physicians ourselves. We're happy to do that either way. So that's a little bit. That's the one kicker in our negotiations with the hospital that really isn't too pertinent to the physician. Yeah. They just need to make sure that they have that COI, and we make sure that COI is in place for every time they work a shift. Right. Yeah. Now, what I will say is that many of the doctors on our platform have worked Locum Tenens for a while, and they prefer to book their own travel. They like to get their points. They like to get, just to submit the receipts. So, I mean, that is something that we're willing to assist in that. But we found that most of our doctors are like, I'm not willing to pay 40%. It's like, oh, well, we help coordinate your travel. And it's like, actually, I want to do that myself because I want the points anyways. And you book me a terrible hotel every time I go and all those things, right? So we kind of have two options where the doctor can book the travel themselves, or we use Ramp, which Ramp has taken off and it's absolutely incredible. And we use Ramp where the doctor, we issue them a credit card and you say, you can book all your travel on this. We'll get sent your receipts and everything. It'll be very simple. And that's a perfect example. I'm sure no agencies are listening to my strategies, right? No agencies are listening to this podcast, but if they were, there's a really good little tidbit for them, because nowadays it's very simple, right? And it's going to be soon that agents are going to be able to look at this assignment and say, doctor, you are currently in Dallas, scheduled to work in Austin, and you clock in this date, you clock out this date, here's the hotel, here's the travel, here's all these different things, and then send them everything they need. Like we're 6 to 12 months away from that. And so that savings gets passed on to the physician and to the health system themselves. Mm-hmm. Sorry, we also don't have headhunters, right? So doctors refer other doctors onto the platform, and that's where our biggest savings are. Like the agencies have these people who are cold calling and text messaging doctors. That's not how we operate. We operate off of referrals only. And so a doctor can refer a friend onto the platform. And when they refer a friend on the platform, that's how we grow. So we don't have these headhunters that are going out there, call in and then also taking an additional 10% of every time that doctor gets connected somewhere, which is probably the case, right? And so the physicians are really what drive the growth on our platform.
Yeah, I saw the word of mouth, how strong that is. Just the transference of trust. Hey, I've experienced, I've gone this way. You should talk to Joe and his team. Paul and I continue to talk to people, right? The wellness, the burnout, the things of him. More so, we're hearing now about impact of AI in medicine and different specialties. Can you share? I mean, you've got a wide breadth of experience, personally, administrative, different things. Can you share a little bit about what your thoughts are around how AI is going to impact the physician market and how what you do may actually help physicians to be able to continue working?
Yeah, I love this question. So if I were a physician and AI were entering into my work environment, I would be asking myself a few questions. First, I would say, who gets the benefits of the efficiencies gained, right? So let's say that you are a clinic and understand the ownership structure of the clinic, but they're going to bring in ambient AI to help you chart quicker. Great. Now do I get to clock out earlier, or am I expected to see more patients? What is it, right? And so I think that's what scares me from an AI perspective, from a physician perspective. Radiology reads, right? Like AI is helping a lot with image reading and different things. Perfect. So now what happens? Now I'm expected to do more reads in an hour, or I'm actually going to get done sooner, or I'm actually going to get paid more. Who gets the benefit of the efficiencies gained? Is it the doctor? Is it the patient? Or is it the company that you work for, or the organization, or the employer? Right? It's going to be a little bit of mix of all of those. But if I were a physician, that's a lot of where my questions and concerns around AI would be. Is that I'm very excited about it, but I also have to be very concerned about okay, but how are we leveraging it into our practice to help administrative tasks fall off my plate and maximize my efficiency, but also my personal earnings? Because again, we can't generate revenue without the physician. At the end of the day, that prescription still needs to be written. Doesn't matter if AI helps diagnose and do all these different things. That signature of the doctor is the one that's generating the revenue. So there's got to be some understanding there in terms of how AI is going to play a part in how physicians operate, which I think begs the bigger question about physician employment models and like you're kind of saying, like burnout and what's the vehicles. And I always like to share this like the fable of, you remember the story of the scorpion who needed a ride across the river and, asked the frog hey, can you give me a ride across the river? And this frog's like, no, you're going to sting me. He's like, well, why would I do that? If I sting you, we'll both drown and we'll both die. And the frog's like, okay. And then they start swimming across the river and make it halfway. And the scorpion stings the frog. And the frog says, why did you do that? Now we're both going to die. And he said, it's in my nature. Right.
Mm-hmm.
And so I kind of, because I'm a scorpion. That's what I do. Mm-hmm. And so I think that physicians are starting to understand that a little bit more when it's when you go into a contract, an agreement, an employment model, understand what the relationship is. That's what's going to drive your satisfaction. Don't go work with a group that you're like, I don't like working in, whether it's the private equity group or private groups or academic medicine or a rural hospital. Just understand what the levers are that they pull that might be frustrating, but that's what's in their nature. It's how they're going to operate. It's what they're incentivized to do. It's what the hospital's incentivized to do. It's what the company's incentivized to do, right? They're incentivized for an exit. So just know that things are going to change, and know that your revenue model is going to change, and know that they're going to push AI. But when they're pushing AI, they're also pushing efficiency gains so that they can maximize margin, because there is this corporate side of medicine that physicians haven't thought a ton about, that I would be thinking a lot more about as AI is starting to come in, about help me understand the economies of what you're asking me to do, because that seems like there's a whole lot of upside for you and not as much upside for me in this situation, right?
Yeah. And I don't know that that makes it bad on either side. I think it's more about helping them understand that that's the nature, as you said, and that it is a business, and that, understanding where they can maximize or create space or opportunity or choice, which is what seems to be the case. I want to frame up a question because, you mentioned that the dating site and gave a couple of other analogies, but, with that, a dating site works really well if there's both parties, right? People that are interested on both sides. Then you talked about Uber, right? And I was thinking, oh, God, we use it. It's about ease, but it's also because it's kind of predictably better. Not to bash on the taxi drivers, but I would think that's it, right? I mean, we generally choose an Uber because we know we're going to get somebody who has a clean car, generally, going to be a nicer experience. But then that got me thinking about what you said. Hey, some of these hospitals are hiring and paying more for a bad physician. I don't want to label as anybody bad or good in that situation, but the reality is that exists, right? Mm-hmm. And so I'm framing that up because I'm wondering if, as you're building this out, right, you're doing this great part for the physician, but to also be attractive to the hospitals. Is there something that you're doing on that side to make it more predictably high quality? Is there something that I guess more directly is keeping bad physicians off your platform so that more facilities and hospital systems would go, we got to go to SendIt because we're going to get better quality there. Not only the pricing, because like you said, I'll pay if I get good quality. Mm-hmm. So is there something that you're working on there that is predictable?
Yeah, that's a great question. And it is definitely where my head is focused, because I'm big on making sure that my staffing and my culture and my schedules are filled. And what does that look like? And so from my personal experience, having worked with agencies, many a times there would be doctors that didn't show up to a shift, right? These doctors, and a lot of doctors that are working in the locum tenens space, they've cast their net far and wide, right? They're getting credentialed at 20 different hospitals and trying to see, okay, who's gonna be the best bid or what's gonna be most convenient. And it's not their fault that the whole industry is broken, right? Because there'll be so many times that they can't get a doctor through credentialing. So we would credential 10 doctors just to fill one vacancy, which was crazy. But we would be so nervous that only 2 or 3 of them would actually end up making it through, because by the time you get to that 90 days being done, only 2 or 3 of them last, and you need to use those 2 or 3. And so I'm like, this is complete waste of resources on the hospital side to go out there and get all of these doctors. And again, they're not even interacting with the doctors. They're interacting with the agency, and the agency's talking to all the same doctors, right? And then they're like, oh, I'm presenting this doctor, I'm presenting them there. And then eventually it just all winnows down. And at the end of the funnel is where patient care happens. And it's very, very difficult to find the right match of the doctor and the hospital for that patient care. So what we are doing is just allowing them to see that doctor's calendar ahead of time to say, hey, this one's actually going to be able to work. We also have ratings and reviews, like I said, but the medical director does review the doctor after they work a shift, right? Now, doctors on our platform can only get ratings and reviews and references from other doctors. It's not like a patient can come onto a platform and say, oh, this doctor sucked, or a nurse can do this, right? Or even an administrator, because the things that I value are much different than what a physician values, right? I'll be like, oh, the doctor was slow and not efficient, but physicians are generally okay with other physicians reviewing them and talking and having a conversation, right? And so that's what we do, is we allow for that on the platform as well. I think bringing that visibility up front, kind of, again, like LinkedIn, where it's more of like endorsements, more like I really, really like this individual, versus like LinkedIn isn't a place where you go to say, this person sucks, don't ever hire them, right? Like you don't do that on LinkedIn. Right. But certainly if we got that on the platform, which we've only had to do once from a doctor, that we had to remove them from the platform because they just didn't meet the quality. But again, sometimes you get what you pay for. That doctor was very affordable on the platform, and there was probably a reason why they were very affordable. Like I presented all the information, right? They had a bad malpractice history. They had all these different things, but the hospital was desperate. And I was like, okay, well, just know, at least you know what you're getting before you go in, right? And knowing the nature of something, like we just talked about, knowing what the nature is, then it makes it easier for conversations to say, okay, hey, look, SendIt was very truthful about this. We knew what we were doing. We don't blame SendIt for this situation, right? We blame ourselves for being in a situation where we weren't willing to pay, or where there was an emergency and we didn't plan properly. Well, that's when you're going to pay more, is when there's an emergency and you don't plan properly, right?
Well, look, I mean, if you are willing to remove somebody off the platform, that doesn't sound good. And like, oh, well, I'm not going to use that. But at the same time, again, it creates this assurance that you're trying to clean your database of staffing, if you will, for those hospitals. And then now some of those people who are casting that wider net, maybe they take your site a little bit more seriously because they can be removed. I don't know if that works that way on other staffing agencies or not.
No,
but certainly I would. Hey, if I'm going to get kicked off of the site that is going to likely pay me more and easier to work with, and is going to be more attractive to hospitals. I mean, that kind of, you have to at least create that threshold where you're helping those parties meet at an equal footing, if you will, right?
Yeah, I mean, Uber has it, right? If you're below 3.5 stars on Uber, you can't drive for Uber, right? That's and again, like, it doesn't happen hardly ever on our platform, right? It's not a common thing, but I believe that transparency creates accountability. By taking out the middleman as much as possible, a doctor is naturally going to understand more that I need to be accountable because they know exactly how much I make. So I'm going to make sure that I don't drive a Ferrari when I'm there on an assignment, right? That I don't go rent a Ferrari, that I understand that I'm being cognizant of, hey, this cost is a little bit more, but I'm here to support you in your patient care, and I'm here to be a good partner. The doctors really like that on our platform. The ones who don't like that probably are not going to join the platform. The ones who don't want transparency, who want to hide behind something, and to your point, I'm kind of okay with that. I've been on the other side of the table where I've been presented something by an agency, and 2 weeks later, I have to say, no, we need to drop this person immediately. Their patient care is like, they're very mean to staff and all these different things. And now I'm back in a hole. And that would ruin SendIt's relationship in a heartbeat, right? Like that, all of a sudden they'd be like, I'm never going to go back to that platform again. I don't care how much money I saved. The ones that they connected me with were not ones that were quality. Again, that's why we only work off of referrals right now for other doctors, because good doctors tend to refer other good doctors on here. The doctors who are not afraid to say, hey, I'm willing to make $30 more an hour, and also ensure, because I believe that's what I'm worth. And I know that I'm going to provide good quality.
Mm-hmm.
Do you think without COVID, you brought up COVID in the beginning, right? We've seen the impact. Do you think that the impetus for this from physicians saying, hey, I want to find a different path. I want to find more balance. I want to find not the traditional deep roots. I'm going to go in this. Do you think that would have happened eventually? Or do you think COVID was just this bump that threw everybody to reevaluate the next 5, 10, 20 years of their career?
I think COVID accelerated things. And I also believe that COVID accelerated the IMLC, that compact license that was not very common, because we see surges in different cities and states, and we couldn't get doctors to switch from one state to the other in time. And so now almost every state in the next 2 years, I guarantee almost every state's going to have an IMLC and allow for it, which has nothing to do with COVID anymore, just to deal with the fact that you've got different surges in patient volume, or you've got a lot of people moving from New York to Florida, and this community is booming. And how do I get enough doctors over here? And so I do think that COVID accelerated it, but it's also keeping it in line with where it needs to be, which is, how do we ensure a more fluid workforce? I think we've always been concerned about a fluid workforce within physicians. Like, physicians can't do gig work like nurses, which is totally true. Like, that's why we don't do nursing. We're not a nursing marketplace. We don't have nurses and doctors. They're completely different in how they operate and what the relationship looks like, right? Our doctors travel in and pick up 5 shifts and then they go home, right? They don't stay in the community for 13 weeks and get paid. And, I love nurses and how they are, but like, it's just a very different model than a physician model. And so that's why we are a physician marketplace. And we will do APPs as well, but we're a physician marketplace because there's a different way in terms of how they operate.
You're talking about that hybrid physician, right? And that what you're describing there, which is different, the pros and cons of W-2, the pros and cons of W-2 plus 10, and helping them understand that. One of the things we bump into a lot with our firm is just helping a physician understand tax benefits, understanding what it looks like on this side, the pros and the cons of what that would look like income. Can you kind of speak to that a little bit? What does a physician go through when they reach out to someone like yourself that says, okay, this is the path I've been on. I've been W-2 the whole time, and talk about that hybrid physician type role?
Yeah. So all the physicians on our platform are 1099, and a lot of them are looking forward to that 1099, whether it's a side gig or, like you said, a hybrid model, right? Where they might be working someplace where they commit to 7 shifts a month, and then they're working 1099 on the side, maybe another 5 to 7 shifts a month, right? And they like that 1099. They can write off certain expenses. They can write off their car. They can write it off in office. They can do things that they couldn't do with their W-2. So it just kind of depends on what state of life you're in, right? And if you need that stable income, that W-2 that has health insurance benefits and other things like that, then perfect. Then keep your W-2, or maybe figure out how to manage that hybrid way. I see it happening more and more, especially with residents that come out. They're like, oh, yeah, no, I work here 10 shifts a month, and I signed a contract with this academic medical center for 10 shifts, but I pick up 3 shifts a month out with a locums agency. And it's like, I enjoy the 1099. I use all that money to pay down my student debt. And I just, you guys know more as tax professionals about it, but we see doctors all the time that are joining and they're putting their LLCs, which I don't care who I pay. You're a 1099. Like, give me your W-9. And it's like, perfect. We will pay you and we'll pay your LLC. And how you manage your LLC is completely up to you. Our contract just states that at the end of the day, you are the person providing the care, right? You can't have an LLC on our platform and say, oh, here's the 10 doctors that I have through my LLC. It's like, no, that is you, right? Yeah. That is your LLC. Yeah. Again, if you give me an LLC that has 10 doctors associated with it, I don't necessarily care. When you accept a shift, that is you working the shift. You can't go to your LLC and then plug somebody in and be like, oh, I found a different ER doctor to work here. It's like, that's not how it works, right?
No subletting.
Yeah, no subletting. Exactly.
So why do you think the industry even tolerated it this long? It seems like this is long overdue.
Yeah, it is. It is long overdue. I don't know. I ask myself that question all the time because it was funny when I had this idea probably 3 years ago. I was looking for a solution. I was like, there's got to be a physician marketplace or something out there, and I couldn't find it. And so I was like, man, I've got this idea and it's amazing, and I'm not going to tell anybody about it. And now that I've been doing it for 2 or 3 years, it's not something new that is like, whoa, this is crazy. Like, how did you think of this? It's more of the fact that it is a challenge, right? The chicken or egg problem, the cold start problem in marketplaces is real, right? We get doctors who sign up all the time who don't have a match for a few months, and that's difficult, right? I would love to be able to match, but we need the doctors to get the hospitals and hospitals get the doctors. So I think there's been a lot of companies that have started up, have the best intentions, but they end up failing along the way. There are a million ways that you can build a marketplace too. And I think that hopefully my unique perspective, having employed physicians, having been on the hospital side, allows me to see where those failures were with those other companies, where it's like, I need to see more KPIs before I make a decision. Does this doctor show up to 100% of their shifts, right? What is the actual cost? What is the average travel cost? Like, I want to know all those things before I make a determination. So hopefully my unique perspective comes in, and I share that with doctors and hospitals all the time. I'm like, I might fail because I have zero idea how to run a locums agency. Like, I don't know. Like, I've never had a locums recruiter. I've never done this. I'm building it strictly as if the agency itself did not exist. I know how physicians think and I know how hospitals think. And I'm going to try and come and bring those two together. And I'm not going to operate within the standards or norms that the agencies have operated for so long, because it doesn't seem like it benefits the doctor and the health system at the end of the day.
Yeah, you don't have to remodel the old house, right? You're bringing something new to the table. It's like, how do I fix that? Forget that.
Yeah.
Build something new and fresh.
Yeah.
Right? Build something better. Yeah.
Well, and just because it's been the way it's been done forever doesn't mean it's the way it should be continued to be done.
Yeah.
Yeah, that's what I deal with all the time, right? It's just like, and that's healthcare in general, right? This is the way it's always been done. But you all know this, like, healthcare's 10 years behind everybody. So marketplace is ripe to start right now, right? It's just like, we are slow and there's a lot of layers to go through, and it's for good reason, right? There's a lot of, compliance issues. There's a lot of HIPAA things. There's just so many things that make it hard to innovate in the healthcare space. But once you do it right, there's only going to be one or two winners when it comes to this marketplace, just like there's only one or two Airbnb, VRBO, Uber, and Lyft, right? Marketplaces have that moat and that density of they feed each other.
Yeah.
So what does success look like for SendIt in the next 5 years?
I would say just complete liquidity within the market and density. That if I'm a hospital and I can come onto your marketplace and find a doctor that I need, and you can deepen my bench, I can connect with them and good to go, right? Like, I don't ever need to go through an agency again. I think that's where our biggest challenge is because we don't have density in every specialty. It gets hard for me to operate with agencies this way and then operate through SendIt a different way, right? Because again, to your point, our platform is very tech forward. So we try and make it easy for the hospital to engage, which is awesome. But I'm only engaging with 3 or 4 of my Locum Tenens, for lack of a better word, through SendIt, and then I'm interacting with 10 others through different agencies. So having 2 different models doesn't work, right? So success for me is liquidity in 5 to 10 years. Is this, if I come onto the platform, I'm going to find a doctor. Uber started by getting all the taxi drivers onto Uber first, right? And they started geographically as well. And so my ideal situation would be every doctor who wants to work Locum Tenens, there's like 100,000 of them, every single one of them will be on my platform, right? And so you might as well go engage with them through SendIt versus going to an agency, because those doctors don't have any commitment to the agency, right? They're not signing non-competes. They're not doing any of those things. Like, they're already gig workers. So might as well list on my platform so that we could have marketplace liquidity.
Well, you're definitely a disruptor, and I think that we've seen that happen in several different industries, and so I it sounds like what you're doing is right on target to me. We talk to a lot of people who are trying to do the locums thing, are trying to get that extra income, and some people are doing it full time because they don't want to be tied down to the W-2 world anymore, and they want more flexibility and more control. So I love what you're doing. For me, this has been great. I loved learning about the changes, not only within medicine, but without, or outside of that with their actual workplace. A lot of the focus that we do, it is that burnout thing, but around making things a little bit easier for them. And so, just to even do a shameless tag, whenever we do planning with a client, it's like, how can we make that easier for them? Right? How can we make it easier? What more can we do in that way so that they can just focus on being a better doctor? It's just a small thought. Like, how can we do that so that they can just be a better doctor? And then that freedom or that lack of mental bandwidth that they're using up from that thing that they're worrying about can free them up to even maybe be better for their patients. And then hopefully that rolls on down to their family, et cetera. So it's a simple stream of how do we just make this one part easier? It sounds like you're doing the same thing. And so very similar alignment for us. So before we wrap the show, I want to ask this last question. And you know the show is named The Patient Physician. And so my question for you is, what does that mean to you?
Yeah, I think what it means is that physicians are so often focused on patients that they forget about themselves and making sure that they understand how can I find myself in a better position, both financially, emotionally, spiritually, whatever that is to them. And I think that there's this awakening that is coming among physicians, hence why this podcast is so great, of how do I care for myself and how do I put myself in the best situation? You talk about greasing the wheels and make it easier for doctors. Like, that's what I want to do. One doctor joked on our platform, like, I swipe left or swipe right? Like, it's like, when I get an opportunity, I'm swiping left or right. I don't have to deal with the monotony of, let's have this back and forth negotiation. Let's have all these different things. Like, the cognitive load of having to make those determinations, like, as a physician, their cognitive load every single day is already huge. So it's like, why do we keep adding and making it more and more difficult for them? Technology should make it easier for them, but sometimes we just add and it makes it very difficult. And so our goal is just to be like, hey, we want to reduce that cognitive load. And I think that's what the patient physician is. It's a doctor who understands that they have to take care of themselves. They got to put their mask on first before they can take care of other individuals. And I think that there's a lot of them that are starting to do that. Right.
Yeah, that's great. Joe, thank you so much for joining us. To learn more about SendIt Healthcare, check out the links in the show notes. And to all the listeners, thank you for being part of the patient-physician community. If you enjoyed today's show, please like and subscribe and share your story with us, because there is somebody patiently waiting to hear it. Have a great day.
Thanks, Joe.
This conversation was brought to you by Physicians Resource Services, a firm supporting medical professionals to improve their financial situation and pursue their personal and professional goals. The Patient Physician is produced in Austin, Texas. Editing and sound design are in the hands of the PodConnects Podcast Network. Please email questions or show ideas to info@physiciansrs.com.